We've invited a panel of experts to help explore and discuss the issues that the data bring up. I'd like to introduce our panel, and I'm really pleased you all came to join us today. First is Dr. Richard Zane. He's professor and chair of the Department of Emergency Medicine at the University of Colorado School of Medicine. Lorez Meinhold is the deputy executive director for the Colorado Department of Healthcare Policy and Finance. And Dr. Jay Want is the Chief Medical Officer for the Center for Improving Value in Healthcare, or CIVIC. Say a little bit more about your interest in this area and any first thoughts that might come to you from the brief information we gave, and I think you've seen the issue brief as well. And Dr. Zane, maybe I'll start with you.
Thank you very much, and thank you for your invitation. I'm thrilled to be here. Obviously, this is what I do for a living, and this is where my career is and what I've dedicated my career to. I think that I would like to push back just a little bit and offer a contrarian view. And one is that the reason why emergency department utilization is high is because it's the best place when you have an emergency. And we deliver care that's exceptional. And the reason why demand is high is because what we deliver is in demand. There are over 130 million emergency department visits per year in the United States, and that's growing. The number of hospitals nationally is decreasing. The number of emergency departments is holding steady or increasing, not at the same proportion. The aging of the population certainly has a lot to do with the increasing acuity that requires emergency care. And I think that looking at an emergency department visit as an untoward event is really narrow in focus. And we really have grown in the last 50 years in our definition of what an emergency department does. And we are really the fulcrum between inpatient and outpatient care. Last year, my father had aortic valve replacement surgery and had his proximal aorta replaced. He was discharged from the hospital in 3.5 days. That surgery 20 years ago had a 10-15% mortality and a 3-week length of stay. That shift of acuity into the outpatient population has changed what emergency departments do. Truly changed. We are not just episodic and unscheduled care, but we are now diagnostic centers. Very appropriately, we will see patients who will stay for 3, 6, 9, 12 hours, will have advanced testing, advanced therapeutics, and be discharged into the outpatient environment or a skilled nursing facility or rehab. The same is true for all segments of the population. What we deliver, what's expected for acute and episodic care, primary care cannot deliver. So I would look at those patients who said, I could have been treated by a primary care physician, and I would say that the last 7 patients I saw last night actually could not have been cared for by a primary care physician, and 5 of them probably would have gone to a primary care physician and would have been referred to me if they had gone to their primary care physician. Also, when we looked at fixed cost allocations and off-scheduled times, primary care physicians are not available at 10 o'clock at night or 3 o'clock in the morning. I am available, and we're available 7 days a week, 24 hours a day. Primary care physicians aren't available usually, unless you're a child, same-day access. And many patients require same-day access because of their acuity or because they simply can't be seen a week from Thursday. I'm new to Colorado, but I'm well insured. And when I selected a primary care physician, it was not easy. When I asked for a new primary care visit, it's 4 months from yesterday. So I don't have any need and I can wait, but we provide a service that others can't. It's not an untoward event, and we really have shifted the paradigm, and emergency care is different from probably what you're envisioning. Thank you.
Ms. Meinhold?
You know, I definitely, we value our hospitals and our hospital partners. They deliver a service that is needed. I think it is trying to get to that deeper level of how do we identify, how do we provide, and what we're trying to do within healthcare policy and financing with our Accountable Care Collaborative is really get to that care coordination. So we can make sure that the hospitals are seeing the people that they need to be seeing, but the folks that can be seen in other settings, and enhancing that communication between hospitals and providers happens. So I think this gives us a good opportunity to look at what are better connections, integrations that we can do to help the inappropriate utilization. Again, there's going to be appropriate and inappropriate, and how do we really look at, and I think what it also helps us do is focus around the Affordable Care Act. You know, there's been a lot of focus on the coverage piece. And again, what this shows you is coverage doesn't impact always sort of where people are getting care. But truly, one of the things we need to address is the cost. And we do know that hospitals cost more, and rightly so for the services they deliver. How do we make sure, again, from that cost perspective, that we are spending what we should be for especially our Medicaid and CHIP patients? That if it's after hours, what are the access points that we can create when it's not an emergency? And so I think it's learning for us, but again, value and appreciate our hospital partners as we do this.
And Dr. Want?
So I read through this thing. I don't know how many of you guys did before you came, but try to make sense of basically the gradients that you see in terms of these people use 20% of these, or 30% of these, or 40%. And the thing I came up with, which is always imperfect in V1.0, is I think this is really a symptom of lack of patient centricity. You got people. Essentially, the people who are going the most are the ones probably who have least access to kind of regular care that fits into their lives, and that last part, because I think that's what's driving a lot of this ED utilization. Yeah, the complexity is increasing and all that, but I gotta say there are a lot of people in emergency rooms that might be seen by your mid-levels or other people who actually probably could have seen a primary care physician. Actually, they may not have even needed to see that. They might have needed to go to Walgreens for self-diagnosis or something like that. And we don't have a system that's actually configured to do that right now. So I think this is, for us at Civic, we're interested in a lower cost, in a better patient experience, and in better population health. This is a symptom on all three axes that our system is not currently configured to deliver the result that we desire. The ED, and I'm not blaming the ED because I think that's like blaming firemen for fires. They're the people basically who are the final common pathway for all the failures of the system. If you don't know what to do, you call 911 and you end up in Rich's ED. And that's not really a smart way to manage a system. But I think that's what we're seeing, is we're seeing system failure at this point, and it is disproportionately affecting some people in the population versus the others. For example, I'm sure the people with concierge care, I'm pretty sure they don't go to the emergency room all that much, quite frankly, for various reasons. But the people who have no regular provider of care, who do not have the moral hazard associated with having insurance and therefore everything costing $25 copay, those people are impacted like big time. And so they have very few avenues in order to be able to get their needs met in a way that fits into their lives.
Thanks for your initial comments. I'm going to throw it open to the group in the room and see if there are any questions.
I heard a brief report on NPR that was sort of a national view of the use of emergency departments. And I'm curious, and this, as I recall, was a conference that was here in Denver. I'm curious whether those results mirror what we found in the CHAZ, and in particular, my recollection was that there was a claim that, at least by the person who was talking, that ED use was, for those that were inappropriate, was not burdensome to the emergency department. Now, I don't know whether that meant there's plenty of resources. Of course, emergency departments are staffed to take on huge disasters, or whether it was more a value judgment about the fact that this, compared to the rest of the work that we do, is really not a burden. Could you speak to that just a little bit?
When we speak about emergency department burden of care, you often talk about emergency department crowding, and I think that's where that comment was on NPR. The causes of emergency department crowding are myriad. The only single thing that's been shown to correlate to emergency department crowding is hospital crowding. So my emergency department, when I feel it's overburdened, is overburdened for one single reason every single time, and that's that I have a burden to care for inpatients that need to be admitted to the hospital, and that's a whole different discussion. The toe cellulitis and the fracture and the ankle sprain and the stomach flu and the cold, things that patients may think their primary care could treat, are not what burdens me. What burdens me is the acuity of disease that requires inpatient services that are not available. If I did not have this burden to care for inpatients, I would never be on diversion, and I would never feel overburdened, at least not now.
One of the things that we've noticed is that those who are covered by Medicaid have higher rates than anybody, right? The uninsured or the underinsured. What are your thoughts about what's happening with that specific population? Why are those rates higher?
I think it goes back to some of the factors about why people use the emergency room. Sometimes it's the after-hours care. I can say this, I volunteer in a clinic because I do healthcare policy and I have to make decisions about healthcare, and so I have to understand what people's are going through as they do this. And trying to find something that is after hours or weekends was really challenging. And so there's one clinic that I volunteer on Saturdays, one or two, and so that access point is really challenging, I think. And so for Medicaid and CHIP patients, that is a place where the hours work and or they don't have a regular source of care. Again, our Accountable Care Collaborative, I might say this a lot, is our effort to really create that care coordination, that connection to a primary care provider or a connection to services so that there is better utilization, so that there is that access. But again, this is a provider access issue that we have struggled with a lot as well. Is it that people should have access to a doctor, a nurse, a PA, sort of what is the right delivery system as we go forward? So I think part of that is what is the comfort level, how do we engage patients and make this truly a patient-centered system. I mean, that is a little bit the rise of the clinics, the specialty clinics, is because it's patient-centered. It's where the patients are at, it's easy to access, and if I have a child with a sore throat or a fever, that's maybe an alternative for me to go to. Though Medicaid and CHIP don't always recognize that as a provider, and so that's why maybe they're not going there but going to the emergency room. I think the other sort of factor, the question I raised and we're doing this, is one of the things we do and we will continue to do is we do enrollment for folks in CHIP and Medicaid in emergency rooms and at medical sites. And so how much of that were they uninsured when they showed up but then realized they were eligible for services? Not that that should diminish the numbers truly, but you know, again, when people are uninsured or even with Medicaid and CHIP, if they can't get into the provider, they're going to go seek care to make sure their child or they are okay. And so that would mean the emergency room. But I think even in our initial responses as we're looking at our Accountable Care Collaborative, the three factors we're looking at are ER usage, readmissions, and imaging. And we've already seen in the patients that are enrolled in the Accountable Care Collaborative a reduction in emergency room utilization.
So my question is on whether any of the mental health burden was looked at in your percentages of patients in these categories. I would be interested to see if that impacted the higher percentage in Medicaid. And then my question to Rich is, in the patients the last 7 you saw last night could not have been seen in a primary care physician's office. Was that because of the medical disease burden or the behavioral health burden or other psychosocial determinants of health that would not allow primary care to take care of that?
So let me have Jeff start with the mental health question as the data question.
Okay. So we did not ask about the mental health burden in the CHAS, although I think that could be an area that we could look into whether there are methods of measuring in future surveys.
And Dr. Zane?
So just anecdotally, of the last patients I saw last evening, of those 7, 5 were too sick or were out of the scope of specialty for a primary care provider. 2 of them, to your point, probably didn't need any medical care at all whatsoever. But if you use the layperson's definition of an emergency, they felt awful. They came to the emergency department. They simply had a disease that there was no treatment for, and it would run its course.
So what is the solution, or a solution? Do we need longer office hours for primary care, more urgent care clinics? What are your suggestions?
You know, I think we see sort of this care coordination, delivery payment reform as part of the model. It's bringing together communities. That includes hospitals, providers, public health, behavioral health, both mental health and substance abuse, to say, how do we create a person-centered system that's going to work, that creates some personal responsibility for clients to understand the differences and how do we sort of gauge where we should be when, but how do we create the right delivery system and then the right incentive system to not necessarily reward volume, but to get better value, better outcomes. And so if I had the exact solution, I would be a sought-after person in many ways. I think there is no clear solution, and I think that's why we're trying a lot of different things. So we passed legislation last year, House Bill 1281, to look at payment reform, which can be anything from global payment to gain sharing to bundled payment, to say how do we get away from the volume to better outcomes. We are doing the Accountable Care Collaborative. We applied for an innovation grant to the federal government to integrate behavioral health into primary care settings as that start of continuum towards integrated. We need better data sharing so that not only do we know if they show up at University Hospital, but did they show up at Denver Health, and how do we leverage tests and abilities that have happened? So how are we sharing data? One, and can we? Two, are we using it to improve clinical outcomes? And three, are we using it not only to share, improve clinical outcomes, but community outcomes? And we have some great examples of what's going on in Grand Junction. And so trying to leverage all of that innovation, I think we will come up with a Colorado solution, but we're in the midst of that transformative time.
In my previous life, I'm new to Colorado. I moved here in April. I worked in a state that had universal health coverage, and I worked in a system that was relatively integrated. And what we found is that after universal health coverage, utilization of emergency services went up precipitously. And after patients were enrolled in a medical home, utilization of emergency services went up precipitously, then leveled off, and then went down below baseline, but not for patients who were new to health insurance. What we did find is that when we had a tertiary quaternary care institution that was integrated with a community hospital, primary care network, urgent care center, the patients who were best referred to an emergency department were those that were referred by their primary care physician or their pediatrician, because it allowed that continuity, that integration of care. Utilization continued to go up and did not decrease for a population. It may for certain individuals because of this increase in acuity, but it's really about, in my opinion, the right patient at the right place and the right time, and making sure that there's seamless communication between those loci of care. But there really has to be a connection of primary care, specialty care, acute and episodic care, looking at the lowest cost for that place, whether it's a freestanding urgent care center or a primary care office or a freestanding observation unit, a community hospital, tertiary, quaternary care institution.
So along that theme of lack of patient centricity, we think we need to start thinking about stuff differently. Because unfortunately, we're not in view 1.0 of this. We're like in 1.4 or 1.5 or whatever. Because we've tried this, extend hours. You have these clinics, you have docs sitting around. They're like, nobody's coming. I guess we'll go back to our regular hours. I mean, let me tell you a story from a friend of mine, Shrikant ER, who is an ED doc at Cincinnati Children's. He said, so we did that, right? We figured out it's an access problem, put up this kind of urgent care site attached to primary care on the drive in to the emergency room. Big sign, urgent care. Patients still drove right past urgent care to go to the emergency room. He said, you know why that is? Because the service is different. How's the service different? He said, what patients really want is minimization of the time between uncertainty and certainty. That's indirect wait time. It's not the time they're sitting in my emergency room. They'll sit 6 hours in my emergency room. Why? Because the results are basically you get them there and nobody will let you go home until they're sure that you're not going to die on the way, right? Okay, so let me go to the urgent care center and do the same thing. Well, it'll be Monday about 7. We'll have somebody call you with that result. My indirect waiting time was like 5, 8, 10 times what it would have been if I go to the emergency room. And still, until we start thinking about this in terms of minimizing that indirect waiting time, until we start looking at it from the lens of the person needing the service and the individual circumstances that surround that decision, I think we're going to continue to tinker and re-engineer a system which was in no way intended to do that. It was really intended to drive volume, to maximize billable services, and maximize the value of each of those units. And that's what we're getting right now. So there are two ways this can happen. I mean, basically, we can re-engineer the current thing, but history shows that incumbents are not very good at that because they have this other revenue stream that they need to kind of continue to run. Or somebody kind of comes in and disrupts the market. And I think with each passing year, we're moving closer to number 2 rather than number 1. With each passing kind of, gee, we tried that and we got a 2% improvement or a negative 2% improvement, I think we're increasing the chances that we'll see disruptive innovation as the solution that will actually change this.
I do want to point out that integrated systems of care do affect ED use. And so we know that if we achieve what Dr. Zane talked about, great communications integration with the medical record, with a nurse call center, with urgent care centers that are actually linked with the triage system and emergency department, all of those are shown to kind of change the overall cost of urgent and emergent care and healthcare seeking behavior. And so part of the issues are what are the solutions to create an integrated system in the setting where there is no integrated system. And I don't want to lose sight of Dr. Wan's comments centered around the patient experience.
So we often fling around the terms inappropriate and appropriate ED usage. I'm just curious if there is a general standard for defining that, and if not, shouldn't we have one?
So I would ask you to say avoidable instead of inappropriate. And there are avoidable admissions, there are avoidable subspecialty referrals, there are avoidable surgeries, there are avoidable emergency department visits, there are avoidable urgent care visits. I think that when you think about why people come to an emergency department, besides the need for immediate gratification or immediate results, it's really an issue of perception of acute and episodic need. And if they can't see their primary care physician, they feel as though they need to see someone. If they can't access their primary care physician and get an answer or reassurance that they can wait till tomorrow, then they are going to need to see someone. And it's not my position to say you can't come and you can't be seen by me, but we as a system have to provide that reassurance, that access, that touch point, so that patients can get the care they need in a timely fashion. Because if you have a patient who's a Medicaid patient and they are employed and you can see them tomorrow at 10 o'clock in the morning, but if they don't go to work and they lose that day's pay, that's not a viable or even reasonable solution for that patient. So we have the opportunity to decrease avoidable or increase avoidable utilization of emergency services, but it's not about the access to primary care or the access to the emergency department. It's really about systematizing and really changing or disrupting what it is that we're doing.
Thank you. I'd sort of like to dovetail on what Dr. Wan said and Lorez as well, but you know, I think the piece that's missing from this conversation probably is the payer conversation, because there are barriers put up by our payers in how we receive our care. For example, if you go to your primary care physician and need an x-ray or a lab test for something, you often have to leave. And in the old days, I used to make deals with my primary care and say, I'll just pay you cash for that so I don't have to put the children in the car, go somewhere, and come back and wait again for my appointment. So in essence, we'd go to urgent care because we could get all that done in one place, or the ED, and for some reason, the payer would pay for it all there. So, you know, I think we are missing that piece of care, and that's another reason why people choose, particularly those folks who have transportation issues, really would choose to go to the ED as opposed to visit their medical home.
So payers are not having a very good time these days. They're, you know, I mean, like on the Q rankings, they're somewhere below, you know, used car salesmen. But, you know, they really have very few functions and very few things that they can actually do about this. So, as I talk to people around the country about payment reform and delivery system reform, this is what I tell the providers, which is you get to do anything you want so long as you're responsible for the overall cost of care, the population health, and the patient experience. And I get to measure it, and I get to take money from you if you don't do it. We call that global capitation. That's been desperately hard for providers to do. But I think that is the quid pro quo. If, in fact, your provider had been globally capped, heck yeah, there would have been an x-ray machine in the office. Why? Because it was more expensive to have you drive down the road to do the thing and then come back with a report, maybe not with a report. And it was not the most effective and efficient way once they're spending their own money. Getting from here to there is a really, really like Grand Canyon times 5, unfortunately. But that's the quid pro quo. If, in fact, we do want that, we ought to not only be pushing insurers to pay in that way, but providers to organize in that way, because that's the only way such a payment and such a responsibility actually works.
About 30 years ago, when most of you were children, we had a continuity group practice at Colorado General Hospital that dealt with the 0 to 10 group, 12 group. And we were able to show that we reduced the avoidable emergency room visits by over 2,000 out of a population we previously had 12,000 visits in the year before this, simply by providing a team with continuity at night. And relating to what you said, Jay, I think the person looking for reassurance is what people need, and if they can do it on the phone, I think they'd be delighted if they trusted the system. Mm-hmm. The problem is our after-hours care, which are linked to hospitals, are predicated on driving business to the hospitals, rather than keeping the mother and baby at home and calling back in a half hour if the Tylenol doesn't bring down the fever. So I wonder if you see the possibility of continuity of care coming back in any of these disruptive innovations. Because to me, that absence drives a lot of the cost that we've currently got.
Yeah, I think it absolutely will be driven by that need. Because we're talking about a visceral need for people, right? I mean, we're talking about an uncertainty that, you know, when I'm ruminating about stuff in the middle of the night, I'm pretty sure that I have some form of terminal disease as I, you know, feel the ache in my back or whatever. We're talking about that. So that being the case, a sense of trust with somebody who can tell you the answer to that and actually follow up, make sure that it doesn't fall through the cracks, really, really important. To get there, there's this terrible dance we're doing right now, which is very difficult, which is, you know, I changed your payment a little bit, you changed your system a little bit, I changed your payment a little bit, we changed your delivery, and each one of those loops or iterations of improvement actually has to work, otherwise people say, see, that didn't work, I'm going back to the fee-for-service gig. So that's how incrementally we're having to do that, but I believe the end result, if you drive from an individual patient's experience is exactly that. And by the way, I'm not sure that involves, you know, all the provider time that we use right now. I think a lot of the, you know, like straight information, it's going to come across this thing. I mean, there are little attachments here that will measure your blood sugar so you can actually report that into a central database. A lot of that stuff is actually going to come in ways that are much more effective and efficient. It will not complete such a transformation until the payment systems actually change such that it rewards you using this and your provider for you using this, rather than penalizing it. Why didn't your clinic take off? I bet there was nearly zero marketing about that. Why? Because it cut off somebody's revenue stream, which actually subsidized the clinic. So that was, you know, not a great business model, not a working business model. But I think you get payment aligned, you get all those things because it does happen to be the most effective and efficient way to deliver the care.
And I do think there's models of that exist, even with some of the recent innovation grants that Colorado's gotten. You know, Denver Health just got their tiering grants to really create the team-based for the sort of separating people by need, sort of what is the appropriate intervention for that, and the team grows as the need grows to really sort of evolve that model. That has been what they've been about. Grand Junction has done a lot of that and trying to evade, you know, the challenge is the delivery system hasn't been supported by payment. But I think with healthcare reform, with this pressure of costs, with Medicaid and CHIP being 25% of the state budget, we are going to push on how do we support those delivery reforms that get better outcome, that ideally lower costs. How do we support that over the long term?
I'm wondering if the CHAZ looked at all at undocumented folks and utilization of ERs for undocumented people.
So we did not, first of all, the CHAZ does not ask about documentation status. It does ask about citizenship status, which there are many non-citizens who are, of course, here in the country legally. But that is that's actually one crosstab that we could do on citizenship status. It's not going to drill down to documentation status, but we just haven't run those numbers yet.
Well, I'd also like to point out how do you ask that question and get people to actually answer your survey? It's a really kind of a difficult issue to say, are you here in the country legally, and then expect any other questions. So I think it's a huge issue, and it continues to be one of these issues that it's hard to bubble up the information on, and as we move forward, we're going to have to wrestle with that.
How much does, or do you think, the practice of, say, practicing defensive medicine comes into play in this? I mean, I can't call any kind of a health care provider and not hear on a recording that, you know, if you feel this is an emergency, call 911, which is the right thing to do, but there's also the flip side of that is that there are some people, you know, are people covering you know, themselves for liability issues and what have you?
Do you mean our primary care physicians referring patients to the emergency department?
Both, you know, referrals and also, you know, somebody comes into the, you know, emergency department. Your, you know, initial assessments are, well, there's, you know, may not necessarily be anything wrong, but then, you know, let's go a little bit further.
So the answer is it's been discussed in I'd be curious what my panelists think, and discussed and looked at the issue of risk tolerance and utilization of resources, mostly around things like high-cost imaging, admission, and consultative services from the emergency department. And we did a study that looked at utilization of high-cost imaging, looked at variability, and then queried the providers to see whether there was an issue of risk tolerance and linked it to their utilization, mostly of high-cost imaging and admission. And we were not able to correlate that, although we're not sure that our methodology was correct to get that. There's a lot of proposition in the United States that there's a lot of cost associated with defensive medicine, and I'm not sure it's gotten clearly to the point of being able to have a causative link, but the feeling is that people are practicing defensively.
So, sorry?
That's okay. Well, this is a really controversial topic, just in terms of what the effect is on the overall cost. I mean, you look at studies like 1% to 2%, and people say it's not a big deal, but it's the emotional deal for the physicians. Okay, so the whole thing about tort reform and all that, I actually think tort reform is the price of admission for American physicians at this point. They're not going to cooperate very well until they get that. The other thing, though, is that in terms of the studies, Rich, is right in that there are some studies that look at people who went from a kind of a at-risk environment to an environment where they couldn't be sued. If you work for the city and county of Denver, there's a cap basically on damages, and so theoretically that doesn't enter into your calculation in terms of whether you order a test or not. Their rate of test ordering actually didn't change. So there's this theory that actually it's somewhat inherent to the practitioner that there is a school of thought that are risk minimizers, and then there are people who are test minimizers. And it is not at all clear that you can convert one type of practitioner into another.
The one thing that we've been able to do to convert high utilizers into low utilizers is show high utilizers that they are aberrant and variable compared to their peers, and the other is to provide very straightforward decision support tools to guide decision making, things like embedded decision support and radiology order entry, so that if you have to order a CAT scan, you answer 3 questions before you can order that CAT scan, and that's one thing that has been shown to decrease utilization. And we would love to do that type of decision support and risk support for almost all expensive decisions, including referring patients to an emergency department or admitting a patient to the hospital, which is one of the highest cost decisions that we make, and utilization of high cost imaging.
So I'm going to take the moderator's prerogative to ask the last question. I think some of the answer has been alluded to, but we haven't really talked about the fact that traditionally underserved populations, African Americans, low-income people, actually have higher ED use, and that seems to represent a disparity. How do you see the interaction between health disparities and emergency department utilization? Any comments?
I think it's representative of all disparities. Underrepresented minorities have lower use and access to many things, including health care, and the access will change their utilization of emergency services. And also underrepresented minorities tend to be lower socioeconomically, which you've shown has also increased the utilization of emergency services. It's really emblematic of how underrepresented minorities are treated.
Yeah, again, I sound like a broken record, but I think that it actually is a measure of lack of patient centricity, and particularly those populations probably aren't receiving care in the way they would like to, and then in the way that fits into their lives. So good example of efforts underway where people are trying to correct that is, kind of the whole Pomodoro kind of movement. It's very widespread in New Mexico, where I do some work. And in fact, so those people in some way function as a translator between kind of the system as configured by the payment system that we have right now, and what people actually need and want on a core basis, individually and culturally. And so I think we can get a lot better at this. I just don't think that we're anywhere close to actually meeting the needs of those populations yet.
And I think it has to do, workforce, how diverse, how comfortable. Again, it goes back to the patient-centeredness. How culturally appropriate is the service they receive. Sort of all those different parts and pieces. How do we create that more patient-centered, regardless of where patients come from, that they feel like the system is there for them and appropriate for them. And so I think there's a lot of work to be done, whether it's in the primary care setting, whether it's hospital setting, workforce training, and it's working with our Promotora program here, Sisters of Color, Center for African American Health. We have a lot of great models here about how do we deliver that care, but I think it's not universal.
Thanks. I want to actually give my thanks to the panelists. It's a very rich discussion. We did a lot of in-depth problem analysis and I think some solution propositions, which I thought were great. I appreciate the questions from the audience, and I thank CHI's analysis and specifically Jeff's work in his presentation today. I'll just summarize quickly the points I think we talked about. That we know that 1 in 5 Coloradans rely on emergency departments for at least part of their care. A large percentage of those would identify that they could have gotten that care from a regular physician by self-report. We know that Medicaid and Medicare individuals have higher rates, and that could reflect those populations. Remember, 0 to 5 was one of the high use groups, and they're more likely to be, Medicaid covers children. I think that's one of the driving issues, and older adults as well have more health care needs. There may be other reasons that weren't identified, that it's not always easy to find a provider who will take Medicaid. We've gotten better with enriching reimbursement rates, but it's still an issue. And now, as we look at Medicare, there could be similar issues in parts of the state as well. I think we have challenges to improving health access and lowering costs that were well identified by our group. It's our hope in providing these information that we stimulate these dialogues between healthcare leaders and decision makers to design those system solutions that will bring down cost and improve availability. Again, we'll repeat the CHAS in 2013. Late next year, we might anticipate the result. I urge you to go to the CHAS website, www.cohealthaccesssurvey.org, for these data, for additional issue briefs that we've published in the past, and for those of you who are researchers, access to the data set itself. I appreciate your time, and again, thank the panel, and I hope you have a great day.